Join us in today's episode. We are in conversation with Dr. Armstrong, who sheds light on the connections between diabetes, neuropathy, foot ulcers, and the critical risk factors for developing these conditions and how individuals can assess their own risk levels. Stay tuned. Dr. David Armstrong is professor of surgery at Keck School of Medicine of USC. He's the leading clinical researcher in the world of limb preservation. He and his team are dedicated to eliminating amputation in people with diabetes over the next generation. Welcome, Dr. Armstrong.
Oh, Shireen, it's such a pleasure to be here. Thank you for letting me play hooky, even at home. It's great.
This is going to be a fun episode. I already know it.
Wheels
with Dr. Armstrong
off the wagon, Shireen, even before we got started. My goal is to lower expectations so all the other smart, great characters that are on this wonderful podcast look even more fancy and great. So there we go. Mission accomplished already.
I think you're actually going the other way. You're elevating that experience right now.
Come on. Low standards in my.
I want to set the bar the other way. I'm gonna set it the other way. No,
we're starting
this is going to be a great episode. Yeah.
That's great. I'm all yours.
And perfect. Well, Dr. Armstrong, welcome. It is such a pleasure having you. Even just starting out with the intro itself and the strong sort of vision, this goal that you have about, we'll get into amputation in just a second, but just starting out there, I want to sort of help our audience, help our listeners just really kind of get a feel for just you and your background. Your expertise spans from diabetes and foot care to tissue, regeneration and wound healing. My gosh, there's quite a bit of experience. How did you grow to have so many different interests, and what led you to this work?
Well, look, I grew up with this quite literally. My father, who passed away about 20 years ago, smartest man I ever knew, but he was a foot doctor. He just worked in the office in Santa Maria, California, kind of north of here in Los Angeles. And so I grew up seeing how someone could really make a difference in this area, just looking at the humble foot. And I learned back then, Shireen, I mean, I guess I could think of maybe two gifts to work in at the end of the body on the foot. And I think, the first one, Shireen, is that in this era, I think we were talking about this earlier offline, but in this era of hubris, and sort of, chest thumping. I can't think of anything that's more of an expression of humility than looking after someone's feet. It spans all borders and generations and religions and even time when you think about it. And so there's that and the humility bit. But then also you were talking about all the things that we're doing. Well, I work on the end of this sort of anatomic peninsula, and my dad used to tell me that. The greatest gift you can give someone besides your love is perspective. And so that unique perspective at working at the end of the body kind of forces you to collaborate, if you will, with the anatomic mainland. And so we're working with, one of my closest friends is a neurosurgeon. I have a cross appointment there. I'm doing brain-computer interface stuff all the way to folks who are working on all kinds of different tools in epidemiology, to spray on and spread on skin, to wearable robots, to everything else in the foot. So it's amazingly that little area at the end of the body is amazingly rich, and so it's a fun time to be doing this whole thing. Fun time to be a foot doctor. And now my daughter, my oldest, I have three girls, but my oldest, they're all great. FYI, the oldest is now going to be a third generation foot doctor. She's actually an intern now at UT Health Science Center in San Antonio, where I was actually a young assistant professor. So that's the whole gang. And by the way, she's being trained by one of my old trainees, Lee Rogers. So boy, look at that, huh? She begat him, begat her in the humble foot. All right. The wheels are already off the wagon, Shireen, in this talk.
I appreciate it. I appreciate it, Dr. Armstrong. I think what really resonated with me with what you mentioned here is, working with this part of the body that is so humbling, right? Like that truly resonates. I do want to give our listeners some perspective around this episode first.
Sure.
I do want to provide first a better understanding for diabetes and its complications, because diabetes is complicated, and then you've got complications that are also complicated. Could you start off by explaining this relationship between diabetes and foot problems? Like, how does that relationship even exist?
Yeah, Shireen. I mean, there's no reason why you should even be thinking about this. I mean, the fact is, very few people care about any of these things, diabetes, but especially the foot within diabetes. I mean, and that's one of the reasons why it's such a big problem, because I'll just summarize it right now. What you can't feel, it's what you can't feel that can really hurt you, and actually can, believe it or not, can kill you. It sounds crazy. People sometimes say their feet are killing them. And in this case, it's possible, but let's just talk about that. So, because there's a lot of bad, but frankly, there's a ton of good. And I think that's what we're going to be talking about now, because it's a really fun time to be doing this, because you can really make a difference. So how does this happen? How does someone with diabetes develop a problem with their feet? Well, over time, folks with diabetes, and I think you probably know, there's about 550, give or take, 550 million folks with diabetes around the world. In the United States, there's maybe 35, 38 million with diabetes. About half of those folks with diabetes over time will develop what's called neuropathy, peripheral neuropathy. And what does that mean? That's just a $5 word for just saying that you can lose some sensation, and you can, therefore, when you lose that sensation, you can wear a hole in your foot, just like we wear a hole in a sock or a shoe. That hole is called a diabetic foot ulcer or a diabetic foot wound. So if you hear me say an ulcer, that's what I'm talking about, not in your stomach, but on your foot. And those ulcers now show up every second now around the world. About half of those wounds will get infected as they're healing. And of those infections, just to hit you with some data, about 20% of each of those may end up in hospital, which is why there is an amputation around the world every 20 seconds. And so the bottom line is that every 20 seconds, that's a problem we think that we can identify and potentially prevent and make a difference. And we can if we get out in front of all this. But those are the data as they exist. I'm happy to also talk to you about how these things can affect folks in terms of morbidity and mortality, if you like, as well, or we could talk about that later.
Yeah, I do want to get into that in a little bit, but I still want to make that connection between, like, how is diabetes causing this, like, and how are we losing sensation? What is happening there?
That's a great. So there are a couple of different ways that folks will lose feeling, or there's several different kind of theories, but really the theories have to do with the fact that you're both having hyperglycemia, so you have impaired glucose kind of control. That can lead to what's called, the $5 word is glycation, or advanced glycation end products, and glycosylation. So what does that mean? That means that the tissue in your body, whether it's tissue in the back of your eye, in your kidney, in your skin, in tendons, can turn from being more like a tortilla, and from that into a cracker, if you will, to use a culinary Yumlish analogy. And so what can happen is that can make the skin more friable and all the other tissue more friable, but it also can make some of the micro little baby blood vessels around the nerve more friable, and that can lead to ischemia around the nerves. In addition to that, this persistent low-grade inflammation can lead to destruction of the nerve as well. So there's a whole lot of things happening kind of at a cellular level, out at the end of the body first, and then it kind of works its way sort of toward the center. So that's why we say that the neuropathy starts in what we call a stocking, like a stocking and a glove distribution. It affects the longest nerves first, which is why it tends to hit the feet before it hits the hands and the other parts of the body. So that is this neuropathy. There's a lot of other little things going on, but that is also why good quality nutrition, food being medicine, good quality glucose and lipid control can potentially reduce the speed at which all of this stuff happens. So the good news is, as people, we have some control over this. Even though I don't think we have control over our genes, we do have control kind of our epigenes and kind of what we can do, collectively to try to affect change. And I think that's where all the information that you provide folks all around the world can make such a big difference. Actually, in my opinion, probably even more important than what I'm doing, because food being medicine, this is medicine folks are thinking about in most of the day, whereas they might just spend a few minutes in my clinic, hopefully less rather than more.
Mm-hmm, mm-hmm. And so with the Dr. Armstrong, so help us understand, because to the layman, it may sound, well, you're losing sensation at the bottom of your foot. Like, how bad can that be? Why is that leading to ulcers? Why is that leading to amputation? How is this happening? How do you not know that you have an ulcer?
Yeah, Shireen, that's right. And so I'll just tell you that it is so easy to talk about on a podcast, or even in clinic, or even if I'm talking to medical students, or even family members of folks, or even to the patient. But what's hard is what actually happens, and understanding this and seeing this. And if I were to show you one of these, one of these wounds, and you could just Google them, but you, Shireen, would have more of a visceral reaction to this thing often than our patients do. And we would say, oh my gosh, what a dummy. How could he not have felt that when he was walking on that terrible blister or that callus, or even when he was walking on a nail and he heard the bang, bang, bang of the nail on it wasn't even him that heard it. It was his grandson who heard it on the linoleum, or on the tile. And so that is, you'd say, gosh, how can you be so, oblivious to this? But if that were you, if that were me, right? If I had something on my back, right? Or if you did, or if I wouldn't, it didn't hurt me, right? There could be I wouldn't do anything about it until someone said, hey, what's that? And it's the same thing here. What you can't feel and can hurt you. And you know what, Shireen, you really hit on it. If you were, if you were an evil deity and you were trying to sock it to humanity, you wouldn't pick something that hurt. You wouldn't pick something like a heart attack. You wouldn't pick someone, although those are terrible, you wouldn't pick a stroke. You wouldn't pick someone, something terrible like HIV/AIDS or even cancer. You would pick this because it is silent and it is sinister and it is super common. And it doesn't, and folks don't feel it until they feel it, until it's a really significant problem. I mean, we were just in the emergency department yesterday seeing a patient like this that had walked on a nail for a few days. And how do we know it was a few days? Because that's when he was in the garage making something. Again, I mentioned this was with his granddaughter, and there were some nails on the floor. So we kind of knew that, but he didn't even feel it. So this problem happens all the time, and it's not his fault, right? And it's none of it. And so folks will look like us, they will dress like us, they may even eat like us, but they're not going to act like us because they don't have that gift. One of my mentors, Paul Brand, used to call this the gift of pain, right? Pain is the gift that no one wants.
Wow, that is so deep, because it truly is, right? What do you do when you lose that sensation? Unless you have that sensation, you do not know that you've been injured, right? Like, you do not know about that.
We are trained. Yeah. We're trained as doctors and nurses, just as people, right, to respond to symptoms, to pain. If someone comes into me, my foot hurts, right? And not my foot doesn't hurt, or not my back doesn't hurt, or I don't have a headache, or I'm not having chest pain. And this is the challenge, and this is what led me to be so fascinated with this, because dealing with other types of injuries that we're trained to deal with as physicians and surgeons
Mm-hmm.
and nurses is one thing, and that's challenging enough. But dealing with the absence of it, boy, I'll tell you, that is a whole different world, and it's been kind of an interest of ours and mine for the longest time because of that. And again, this is the easiest thing to talk about, you and I, right now, with all the folks listening, but it's just the hardest thing to understand in IRL, right? In real life, when you're in clinic or when you're in the operating room, right? When you're in the emergency department, or when you're at home and you have a problem like this. The good news, though, Shireen, I'll tell you, is that these problems are identifiable and preventable. And that's the good news.
Yeah. And I would love to, that's where I actually want to go next, because help us understand what are those key steps that a
Yeah.
person who is listening today or is a caregiver for someone who
Yeah.
has diabetes, what are those key steps that they need to take to say, man, I do not want to go through this?
Yeah. So there are definitely steps. So let's talk, first of all, about what you can do before we even talk about like any of the things you could do lifestyle wise. But the first thing is, let's start with the doctor and then move ourselves out back to the home. So the first thing is, when you're in the doctor's office, what can you do? You might be in the family with a family doc, and she or he may be seeing you, or maybe it's a nurse practitioner or a physician's assistant, or another nurse. Here, just knock your socks off. Seriously, just take your socks off when you go in there. And that may seem ridiculous, right? But that will cue her or him to have a quick peek at your feet, because she or he, on a general doctor visit, have so many other things to do that are really, really important for your life, not just your limb, that they're going to they might forget this, right? And it's not not at all their fault. It is impossible to do everything that is expected of a family physician nowadays. But that's number one. So that'll just get them to do that. Number two, make sure that on the doctor end now, and then we're going to back our way into what you can do at home. So make sure that you are seeing your foot doctor, your podiatrist, at least once a year. So, and your family doc will likely be referring you. If that's not happening, there are really good data to show that if she or he is referring you out, just doing that. We just had this paper recently in the Journal of the American Medical Association. I'm sure we can put a link there, because actually just as good to read for you as it would be for any doctor or nurse. But there are really good data to show that if you're doing that, your risk for getting any of these problems like a wound or infection or amputation reduces anywhere from, on the low end, 20%. By the way, 20% change would be a blockbuster drug, to upwards of 80%. So this is blockbuster effects just by seeing your generalist or your diabetologist along with another member, along with a podiatrist. So podiatrist along with another member of the diabetes team. That is what reduces this. And then those clinicians can identify any risk, like if you have loss of sensation, that's dangerous, or if you have a problem with your circulation and you need to see a specialist like a vascular surgeon, or if there are other issues that need to happen. That is a quick and easy sort of thing that you can do. Knock your socks off, podiatrist at least once a year. Number two is, let's talk about at home. So if you're at home now, what are some of the things you can do? So at home, do the same thing. Knock your socks off. Now, it may be really hard for you to see your feet or the bottom of your feet, and unless you've been like a yogi and you can bend and twist your body. And if you are, man, God bless you. That means that you're being active and exercising, and I'd say that's great. But if you're not, then have another member of the family, and that could be your significant other. It could be your grandchild or your child. Just have a quick look every day, and in doing that, that can be a lifesaver, literally. And you'd say, well, what do I look for? And the answer is, well, if you're looking every day, you would know. because it'll be different than it was a day or two ago. And maybe there'll be swelling that's unusual, maybe on one side or the other, or even both. Maybe there'll be redness in an area that's unusual. Maybe there'll be something like an ingrown nail, all these little humble things. Maybe there's something weird in between the toes that you say, gosh, what's that? Or maybe there's a callus. So a callus for a person with diabetes is like a breast lump in cancer. It's a coming event. And if you have a callus and you don't have feeling, that area is about to ulcerate. So you need to see your foot doctor. And I know that sounds ridiculous, just a humble callus, but that humble callus can become a wound extremely easily. And very often there's a wound under the callus that you can't even see because you can't really be feeling it. If it were you or if it were me, it would hurt us so much because we have sensation that we'd be limping on the thing and we'd be in to see our foot doctor, or we would have trimmed it ourselves, right? But that's the difference, really. So those sorts of things are the things you can look at, and you'll be coming in to see people all the time. And we even have a program that we call our Foot Selfie program, where our patients can take a picture of their feet and ping it over to us. And that has actually been really a limb saver as well. And we're really trying to expand that program with resources, not only around our area, but really worldwide too. So that's just a super simple thing. But yeah, definitely take a picture of it, because you can now.
And by the way, I really like the foot selfie because it makes so much sense. It's like, you don't have to necessarily have someone be live on the other side. It could be a picture that you take so you're not able to reach, or you don't have someone looking at the bottom of your foot. Just take a picture, send it over.
Absolutely. This is we've worked with telehealth for a really, really long time. And this is one of those things they call store and forward. That's the fancy word, or storing like something and being able to forward it later. But it's just a picture for us, right? And that kind of thing is becoming more and more common. And that is an enormous benefit that we never used to have, because most of us have these devices now. And when it used to be really exotic.
Mm-hmm. Are there other precautions, Dr. Armstrong, that individuals can take to protect their feet in situations, again, where pain cannot alert them to a potential harm?
Yes. So there are tons of things. There are tons of little things that you can do. A lot of those little things you can kind of garner this by talking to your primary care doctor, your diabetes specialist, or your foot doctor, your podiatrist. But what I'll tell you is, just some little tips is, if you can help it. I know it's easy to go barefoot around the house, but if you have any loss of protective sensation, most of your activity, we've done a lot of research in this area, about 85% of your steps are going to be in the house most of the time for an average person with neuropathy. So, but again, what you can't feel can really hurt you. And a lot of these people that will step on a needle or a nail or something like that, even a little, piece of a matchbox car, all these weird things that we pull out of people's feet, those things are laying around the house, and they're not thinking about the fact that you can't feel anything. So if you can, at least have some slippers around the house. And if your doctor has prescribed you some prescriptive shoes, and by the way, these don't have to be ugly shoes. They can be relatively good looking. They just need to fit you well, and to a point where you're not going to get a wound by rubbing on an area on the bottom of your foot or on one of the toes. But some of these shoes now can be worn obviously around the house. You can have a sandal that you can be made to wear around the house, and then out in the community. So that's really important. The other thing is, during the summertime, definitely wear that sandal outside. If you're walking out on some concrete, you might not be able to feel it, but I just saw a patient, was it yesterday, that went on a holiday and burned all the skin off the bottom of his feet. And again, he's a really great guy. This is like part of our family almost, this patient. All these patients are. But it was just that he couldn't feel anything. And he had walked across the concrete, and that concrete was probably 160 degrees Fahrenheit. And so you'd imagine what happened. So that kind of thing, that's what you can do. If you're in the pool and you have neuropathy, it's okay to be in the pool. We want you to do things. But you might want to get some of those, if you can afford to get some of those aqua socks, those rubber things that you can get relatively inexpensively to put on the bottom of your feet so you don't get a blister on the bottom or the sides. of the pool. But what I tell my patients, and I don't know if this is good doctoring advice, but I'm going to tell you anyway on the podcast, is that I tell most of my patients, and they're going to probably think I'm a broken record, but I say, I would rather you get in trouble doing something than doing nothing, right? And so, because if you do have a problem, you get a wound, then we're here to see you, and we can look after you. And if you're just sitting there doing absolutely nothing, well, then you're deconditioning. It's just that's no good. We just want you to be as active as possible, and we'll try to make allowances for this sort of thing. That's why you want to work with the clinicians around you and your family members to really effect positive change.
Mm-hmm. I do want to get into a little bit around the difference between men and women and how this, and so I'll actually refer back to an article that you wrote around the impact of gender on amputation, in which you claim that diabetic and non-diabetic men were significantly more likely to have a foot amputation, while diabetic and non-diabetic women were more likely to have a thigh amputation. Can you explain why this is the case and what factors really contribute to this difference?
Yeah, well, Shireen, so you're really picking out some interesting stuff. So this is really kind of inside baseball, kind of statistical stuff, but it's not, because it's also there's a ton of sociology here and kind of social determinants here. So let's talk about this. So first of all, men in the past have tended to be less apt, and of course there are aspects that are changing, and from man to man or woman to woman, these are generalizations, massive generalizations that happen to be supported with data, but from a patient to patient, these things may not hold up. But that being said, in general, men are less likely to come in for general wellness checks unless they're actually hurting, and they're more likely to develop many of their complications, their end-stage complications of heart disease, of cardiovascular disease, and metabolic disease. So cardiometabolic disease a bit earlier. Women are more likely to live longer and live longer with some of the other complications. So the men are more likely to actually get an amputation than women in general around the United States and around the world. This is also particularly true for men of color, and whether you are Black or Hispanic Latino, or if you are or if you're Native American. But women are more likely, yes, to get in general to get a high level amputation, like meaning a very high level, like a above the knee amputation. You had mentioned those data, and that is true in general. Often because they may be older when they get that amputation, and they may have even more severe peripheral artery disease, or PAD, peripheral artery disease, also called CLTI, or chronic limb-threatening ischemia. So that's one of the reasons we think why we will sometimes see more what's called AKAs, above-knee amputations, and more maybe BKAs in men. But the most important thing is not that. The most important thing is this, is that many of those problems are addressable early on if we do what we just talked about doing, Shireen, which is knocking your socks off when you're getting into the doctor's office, checking yourself every day at home, and again, there's a bunch of other things in terms of good quality diet that many clinicians have ignored throughout their career, but I think many of us are finding that is even more important than some of the advice we can give people, because this is something that they're doing every day, multiple times a day. And that has more acculturation issues than many other things, food being medicine. So there's a lot that can be done to affect change here. And in those women and in those men, especially those with peripheral artery disease, being treated by a vascular specialist, like a vascular surgeon, interventional cardiologist, or interventional radiologist, can be limb-saving and life-saving with endovascular and open procedures, along with teaming up with the podiatric surgeon. And we call that team for limb preservation, we call that the toe and flow program and team. And if you have the opportunity to see that kind of interdisciplinary kind of toe and flow team, you should avail yourself of that, because that appears to dramatically reduce your risk of amputation big time. So keep that in mind as well.
Mm-hmm. Mm-hmm, mm-hmm. But if we don't, generally though, what we should do is get those foot exams done. Take the socks off. I think that's going to be my one key thing that I remember here is take the socks off. So go to your doctor, take the socks off, knock your socks off. Even if the doctor tells you, that you don't need to, take your socks off and show your doctor the bottom of your feet.
And that'll cause her, that'll cause him just to look. It certainly will do it for me, right? And again, you're not casting any aspersions at all. Hopefully, you're not casting your socks or shoes at him or her either. But what it does is just directs him to that.
Yeah. No, this has been an incredible episode. Thank you so much, Dr. Armstrong. With that, I would love for listeners, to know how they can connect with you and learn more about your work.
Oh, you're very welcome to follow us on Twitter or X, as you were, or Facebook or Insta. I'm sure you can put all that up there on the list, or our blog. The blog is super easy to go to. I think it's called diabeticfootonline.com. Diabeticfootonline.com, and you're welcome just to Google me, David G. Armstrong. You'll probably find stuff at USC at our Keck school in our salsa program. But you're very, very welcome, Shireen. This has been such a pleasure.
Thank you so much, Dr. Armstrong. And with that, to our listeners, thank you again for joining us on another episode. We will see you in the next one. But in the meantime, you know the drill. Head over to our social media, on our Facebook, on our Instagram, and answer this quick question below this podcast episode, a social media post. How do you typically care for your feet? And what aspects of foot care do you find most important or challenging in your daily routine? Head over again to Facebook, Instagram. We will continue the conversation there. And again, tell us, how do you typically care for your feet? And what aspects of foot care do you find most important or challenging in your daily routine? With that, Dr. Armstrong, thank you so much.
Wow, what a pleasure.